Kanski lecture series, and today we are going to start about the glaucoma, chapter 11, glaucoma, and it is one of the very important chapter. It is a bit lengthy as well, but an enjoyable chapter. So let's get started with the introduction. The introduction starts with the aqueous production. Aqueous humor is produced from the plasma by the ciliary epithelium of the ciliary body pars plicata using a combination of the active and passive secretion. A high protein filtrate passes out of the fenestrated capillaries into the stroma of the ciliary processes, from which the active transport of the solute occurs through the dual layer of the ciliary epithelium. The osmotic gradient thereby established facilitate the passive flow of water into the posterior chamber. Secretion is subject to the influence of the sympathetic nervous system with opposing action mediated by the beta 2 receptor, increased secretion, and alpha 2 receptor, decreased secretion. Enzymatic action is also critical. Carbonic anhydrase is among those playing a key role. So basically, in this part, the writer is discussing about the aqueous humor production. So aqueous humor is basically fluid that is present in the interior and the posterior chamber. So you know what is chamber? Chamber is basically the area between the cornea and the lens, and between it is the iris. So the area between the iris and the cornea is called the interior chamber, and the area between the iris and the lens is called the posterior chamber, and both of which connect through the pupil. So aqueous humor is basically produced by the ciliary ciliary body um, uh, of the uvea. So basically, the uvea consists of a choroid, then it consists of the ciliary body, and then it consists of the iris. And the ciliary body itself is divided into pars plana and pars plicata. It is basically the pars plicata interior side which produces that of the aqueous humor. So basically the pars plicata is like epithelium. It is a double layered epithelium. So what happened is that in the stroma, it has a stroma, and the plasma, it is the fenestrated, it has a fenestrated capillaries, mean that there is a porous. So what happens is basically that fluids leak out of these fenestrated capillaries, and they go on to the epithelium, and where they are secreted by the active pump. But after that, when there is a lot of material that goes into that, then the water also comes with the passive flow. So these secretion are basically mediated by the sympathetic stimuli alpha 2 and beta receptor. So beta receptor increases secretion, whereas alpha 2 agonist decreases secretion. So that is why we in the anti-glaucoma drug we give beta blockers and alpha 2 agonist to reduce the IOP. So aqueous outflow. So now that is how the aqueous humor is produced. Now how will you drain the aqueous? So aqueous outflow is through the trabecular meshwork. It can be through the iris. It can be through the uveoscleral tract. So basically the trabecular meshwork. Trabeculum is a sieve-like structure at the angle of the anterior chamber, although through which the 90% of the aqueous humor leaves the eye. It has three components. The uveal meshwork is the innermost portion, consisting of the cord-like endothelial cell covered strand arising from the iris and the ciliary body stroma. The anterior intertrabecular spaces are relatively large and offer little resistance to the passage of the aqueous. So basically, a trabecular meshwork is a portion through which the aqueous humor is drained, and where it is located, it is located between the at the angle of the anterior chamber, means that there is an iris and there is a cornea, so they form an angle, and between them lies the trabecular meshwork. So it has a three components. One part is a uveoscleral meshwork, second is called the corneoscleral meshwork, and third is called the juxtacanalicular meshwork. Every other meshwork is like uveoscleral drain most of the aqueous. Then there is a very much resistance that is encountered at the corneoscleral, and the juxta canalicular has the highest form of resistance. So then the uveal scleral uveal meshwork is the most innermost portion, means that this is an angle, and the innermost portion is the uveal meshwork. Then there is a corneoscleral meshwork, and then there is a juxtacanalicular meshwork. So the uveal meshwork is the endothelial cells that is arising from the iris and the ciliary body stroma, and the spaces are relatively larger and they offer little resistance to the passage of the aqueous. Next is the corneoscleral meshwork that lies external to the uveal meshwork to form the thickest portion of the trabeculum. It is composed of layers of connective tissue strand with the overlying endothelial like cells. So you know that it was considered endothelial cells, and now it also contained the connective tissue as well. So it is offering more resistance. The intertrabecular spaces are smaller than those of the uveal meshwork, conferring the greater resistance to the flow. So next is the juxtacanalicular cribriform meshwork is the outer part of the trabeculum and links the corneoscleral meshwork with the endothelium of the inner wall of the Schlem's canal of Schlem. It consists of the cells embedded in the dense extracellular matrix. So it is a cells that is dense matrix with narrow intracellular spaces and offer the major proportion of the normal resistance to the aqueous outflow. So basically it connects the uveo corneoscleral meshwork with the canal of Schlem. So first basically the trabecular the aqueous outflow goes through the trabecular meshwork, and then it goes to the Schlem's canal. So what is the Schlem's canal? The Schlem canal is a circumferential channel within a perilimbal sclera. The inner wall is lined by the irregular spindle-shaped endothelial cell containing enfoldings, giant vacuoles, and are thought to convey aqueous via the formation of the transcellular pore. The outer wall is lined by a smooth flat cells and contain the opening for the collector channel, which leaves the canal at an oblique angle and connect directly or indirectly with the epicleral vein. Septa commonly divides the lumen into 2 to 4 channel. So basically this is a cornea, and this is the rest is the sclera. So Schlem canal is present at the perilimbal area. So basically it is a canal, and it has an inner wall and an outer wall. The inner wall consists of the endothelial cells, and the outer walls consist of the flat cells. And the Schlem canal also have a collector channels, 2 to 4 collector channels through which it is drained to the epicleral veins. Physiology. Aqueous flows from the posterior chamber via pupil to the AC, where it exits the eye via 3 routes. Trabecular outflow, 90% aqueous flows through the trabeculum into the Schlem canal and then epicleral vein. There is a bulk flow pressure sensitive route, so that increasing IOP will increase outflow. Uveoscleral drainage, 10%. Aqueous passes across the face of the ciliary body into the suprachoroidal space and is drained by the venous circulation into the ciliary body, choroid, and sclera, iris. Some aqueous also drained via the iris. So it is showing the scanning electron micrograph of the trabecular meshwork. It is showing the anatomy of the outer channel. A is showing the uveoscleral meshwork. B is showing the corneoscleral meshwork. C is showing the Schwalbe line, so it is the end of the Descemet membrane. D is showing the Schlem's canal. E is showing the connectors channel, and F is showing longitudinal muscle. G is showing the scleral spur. So basically it is showing that there are 3 routes of drainage. A is showing us basically the major portion is through the trabecular meshwork that goes from the trabecular meshwork to Schlem canal to epicleral veins. The B is showing the choroidal root. Basically it goes from the uh, ciliary body into the suprachoroidal space, and the third is that is of showing that one is going through the iris and it is a very small portion. So intraocular pressure is determined by the balance between the rate of aqueous production and the rate of aqueous outflow. So basically it is a balance between how much aqueous humor is produced and how much it is drained. The latter is related to the factor that including the resistance encountered in the trabeculum and the level of the apicicleral venous pressure. So drainage depend upon how much resistance the encountered at the trabecular pressure and how much is the apicicleral venous pressure. When it is high, there will be the resistance to the outflow. Concept of the normal intraocular pressure. The upper range of the normal for adult is 21 millimeter mercury on applanation tonometry. Some individuals develop glaucomatous damage with IOP less than 21 millimeter mercury, but others remain unscathed with IOP well above this level. While reduction of IOP is a key modifiable element in all the types of glaucoma, additional incompletely understood factors are critical in determining whether a particular individual or eye develop glaucomatous damage. These include factors affecting the susceptibility of the optic nerve to damage, such as the integrity of its blood supply and structural vulnerability to the mechanical stress at the optic nerve head. So basically it is showing giving us the concept of the normal intraocular pressure. Generally we consider the normal intraocular pressure between 11 to 21 millimeter mercury is a normal, but it is just demographic based reading. Some people even show glaucomatous and the pressure less uh, at an pressure less than 11, and some will not even show the damage greater than 21. So these are all the individual person that how the glaucoma is IOP affects in different persons. Second is that it is the only modifiable it is the usually the key modifiable factors in the glaucoma. So basically in a case of a glaucoma, when you modify the IOP, most likely the disease get controlled. So it is one of the modifiable factors in the glaucoma. So fluctuation. Normal IOP varies with the time of the day, diurnal variation, heartbeat, blood pressure, and respiration. So IOP is basically the pressure of the eye that uh, usually can have a changes with the time of the day. It can occur with the pulse rate, blood pressure, and respiration. The diurnal pattern varies with the tendency to be higher in the morning and lower in the afternoon and evening. This is at least partially due to a diurnal pattern in the aqueous production, which is lower at night. So at the morning we will have a spike of IOP. Why? Because the production is lower at night. Glaucomatous eyes exhibit greater than normal fluctuation, the extent of which is directly proportional to the likelihood of progressive visual damage, and a single reading may therefore be misleading. It is a good practice to note that the time of the day in conjunction with the recorded IOP. So basically sometimes you when you measure the IOP, the IOP comes out normal, but because of the peaking, sometimes the glaucoma IOP gets peak and you did not get the reading at that time. So if a patient's come to with you with the glaucomatous optic neuropathy and the pressure is normal, you tends to do the diurnal pressure so that you can know that any spike of IOP during any time of the day and notice any kind of diurnal variation. And measurement of IOP is discussed in chapter 1. It is usually basically through the applanation tonometry. So that's it for the part glaucoma part 1. See you in the next lecture.